we knew for years that patients in intensive care units get really confused, right? So back in the 90s and early 2000s, delirium was just starting to get the attention that it deserved. Back then, we knew it was common. We knew people got confused, but people weren't using the right language at the time. We used to call it sundowning and all these different terms. And at Penn, we used to refer to it as the just ain't right syndrome. We didn't know what was wrong with the patient, right? But we knew there was something just ain't right.
Now I want to know, was that an official diagnosis?
That was the official diagnosis that we used on our unit for some time. But as the science developed, we began to recognize this syndrome of confusion, what we used to think of it as delirium. And we also at that time really thought it was a pretty benign thing, right? You're old, you come to the hospital, you're sick, everybody's gonna get confused. And I remember back then even telling family members myself, I remember this very clearly, it's okay. Everyone gets confused when they come to the hospital. They'll definitely get better by the time they get home. We'll take care of them, we'll keep them safe. And now thinking back on those comments, oh boy, was I wrong, right? So this last decade has really shown us that this confusion that we now know and have a definition for as delirium really is a consequential problem. It affects most people that are admitted to the ICU, particularly people that are on mechanical ventilation. We know that it has associated with serious problems, both in the inpatient setting, but more importantly, we realize that, having an episode of delirium while you're in the ICU really can affect you long term, not only the patient, but the family members. And what I mean by that is, there's been evidence suggesting that, when you're confused in the ICU and you go home, you have cognitive changes. And these cognitive changes could be pretty severe. Like it's been compared to traumatic brain injury. Those patients, they're very difficult to care for sometimes. Alzheimer's disease, that's how much brain injury is happening during the course of an ICU stay. Now, of course, some of it's probably related to the reason that they're in the ICU, right? The reason they came in. But we know that a lot of the things that we do in the ICU that we really thought were the best things for our patients, that we did for very good reasons, we know that those common practices are actually causing more problems than what we were initially trying to treat the patient for. So, for example, when patients were on the ventilator, there was, and there kind of still hangs around, this belief that when you're on the mechanical ventilator, that you need to be deeply sedated. Right? As nurses, we would talk to each other and say, if I'm ever in the ICU, make sure, and I'm on the vent, make sure you keep me sedated. I don't want to be awake. I don't want to remember anything. So our practice was to keep them comfortable. We're kind, compassionate people, right? We don't want to see human suffering. And that's core to nursing. Core to nursing is relieving human suffering. So we
not
did
causing
what
it.
Not causing it, right? Exactly. And so we did what we thought was right. We gave pain medicines, benzodiazepines, so that we can purposely give the patient amnesia, right? Our thought was, who would want to be remembered in the ICU? 15 lines and tubes, catheters everywhere stuck in your body. And we kept them very heavily sedated with the thoughts that we're helping them forget this terrible experience. But we now know that that practice of deep sedation in particular is very harmful to the patient. It hurts their brains, it hurts their body, it makes them decondition, weak, a lot of physical and functional disability associated. So that's just one example of the practices that we did, well-meaning and well-intentioned, that we now know actually hurt our patients.
How did it hurt them?
So like problems thinking when they get home. And it's sometimes difficult to pull out what it is, exactly what practice in the ICU alone is causing these really bad long-term outcomes. I mean, that's a huge change for us too, let's remember. This focus on intensive care being focused on not only saving lives, but in the short term, immediate focusing on let's keep their heart beating, let's keep them cognitively intact, and let's keep them alive. That's never going to change in critical care nursing. We have to do that. But the change to thinking about or knowing that what we do in the intensive care unit actually has an impact on those long-term years, whether or not they'll survive, yes. What we do affects whether they'll live or die, but also how they act or interact with their spouses, their loved ones when they leave the hospital. That's a relatively new recognition.
How did that come about? I mean,
So, it's very interesting when you look at like the history of the science. So it developed in like stages. I'm going to say that in the 90s I'm going to say around 90s, 2000 is when the ventilator trials that show low tidal volume was good for patients came out. So we had this practice of deeply sedating using neuromuscular blockade to facilitate these vent changes. So there were several studies that came out that looked at the effect of shutting off a patient's sedation once a day to see what that had on patient outcomes. So once a day, just shut off their sedation, wake up their brain a little bit, and see what effect it had. Or lowering the sedation, or choosing the right, what medications, studies that looked at, is this medication worse than this medication? And the sedation studies developed and showed that, minimizing sedation helps patient come off the vent earlier, helps them with a lot of great outcomes. Then around the same time, there were studies that came out and said, maybe patients are ready to come off the ventilator earlier than we think they are, right? So very brave pioneers in the field did this study, and actually, kind of sounds scary, right? This is when I tell people what I do, they go, are you kidding me? But they did this thing called spontaneous breathing trials, and what they did is basically shut off their ventilator and let the patient breathe on their own. Who would think you could do that, right? I mean, they do it. Critical care nurses know, you could do it in a number of different ways. You could put them on a T-piece, you could change their vent so they're doing all the work, not the ventilator. Guess what? That helped patients get off the ventilator earlier. So playing with their sedation, playing with their ventilator, letting them breathe on their own helped. Now that there was some evidence showing that patients who are off sedation or have sedation minimized had better outcomes. Patients who had, so we'll call that the old A in this bundle that we'll be talking about. And now that we showed that breathing trials help patients, what if you combine them both, right? What if you shut off the patient's sedation and shut off their ventilator at the same time? Now that's like really mind-changing, right?
Right.
Can you imagine how much stress those people must have faced trying to convince ICU nurses, yeah, let's shut off their sedation and their ventilator at once and just see what happens, right? But guess what? There's this groundbreaking trial called the ABC trial that did just that, right? They explored what happens if you shut off the ventilator, shut off their sedation, what happened to them, and guess what? They had better outcomes than the patients that didn't get it. So now we have this ABC, awakening, shutting off their sedation, let's wake up their brain, breathing, let the patient breathe on their own, and C, coordinating those two efforts. We know that works, right? Well, now that patients are awake, the next step was, and in this time, like all the science was developing around delirium, knowing, that delirium's bad, and some of the medications like the benzos, push people towards developing delirium. So that's the D, right? So we have the A, B, C, D. Now we have patients in the ICU that are more awake, cognitively engaged, but they're kind of laying in bed doing nothing, right? Not really engaged in any kind of walking or anything like that. So several studies came out that looked at the effect of early mobilization. E, now isn't that brilliant? Now that these patients are awake, can we get them up and moving? And what's the effects if we got them up and moving while they're in the ICU? Again, probably got some pushback there, right? Okay, now we want to get our patients up on the ventilator and walk them. Right, that's asking a lot.
Scary.
It's scary. It's hit it right on the head there. Scary, right? One of the big challenges to all of this. Again, great outcomes. So looked at physical function, physically when they left the hospital or better, get off the ventilator earlier, better quality of life in the long term. So we have this whole bundle of interventions that are coming together, ironically, or maybe not ironically, a lot of thought behind this from a lot of the scientists in Vanderbilt University, but noticing this ABCDE connection, and it was proposed as a bundle. So if we know these interventions all work separately, what happens if we put them all together? So that was the first ABCDE bundle, right? Let's put them all together and see what happens. So when I was at Nebraska, University of Nebraska, we did kind of the first test of the ABCDE bundle. It was a pre-post study, so we looked at patients before the bundle went into effect and after the bundle went into effect and what was the difference in their outcomes. By using the bundle, we were able to decrease delirium in half. We have the odds of delirium. That's huge. Half. Amazing. When you think of all the bad stuff that's associated with delirium, boy, is that good, right? Better ICU length of stay. We got them off the ventilator 3 days earlier. Good things, right? Then there was another study that actually 7 centers did kind of the same thing, but they changed the bundle a little bit. We're going to start talking about the F in a minute, the family engagement piece of it. The other study had 7 hospitals in the Sutter Health System, and looked at the same thing, and guess what they found? When you use the bundle, patients get better. But they had a very interesting finding, which I think a lot of nurses really need to know. That study was actually the first that looked at what happened if you get like incremental doses of the bundle. Instead of giving it all or nothing, what this study suggested was that the more parts of the bundle you get, the better the outcomes, showing that there was kind of like a dose response. So that was a great addition. Now last year, we just finished, the Society of Critical Care Medicine just finished a learning collaborative. It was 68-bed learning collaborative, quality improvement collaborative, whatever you want to call it, that was dedicated to the ABCDEF bundle. So what's the F, you may ask?
Family.
Family engagement and family empowerment, right? So adding that important F piece, engaging those family members to be active participants in care. In the collaborative, we really defined it, and we really kind of focused initially on getting family members into the care circle, the interprofessional circle. So when we're rounding in the mornings, the interprofessional team's rounding, inviting the family, come join us, come listen to us, come teach us, right? They can teach us a lot about the family. The Liberation Collaborative focused on that ABCDF bundle, and we just had the results of that work published. Again, fantastic results. 68 hospitals, academic medical centers, community hospitals, everywhere in the country, great outcomes when the bundle was utilized. Same finding that the more parts of the bundle you get, the better for the patients. So really making tremendous strides in providing patient care.
That's wonderful. I think adding the family, because if the patient has family, they can be an integral part in the successful rehab of the patient afterwards. They're going to be taking care of the patient when they go home.
Absolutely.
And I think that empowers them to be able to do that.
Great word, empowers.
So it sounds like that it has been a successful bundle.
It's evolved. Hopefully you've seen the evolution. Like the A now is actually assess, prevent, and manage pain. And then the B is both spontaneous awakening and breathing trials. So there's been an evolution, and the F was added. So it's a great bundle. And it's a great bundle because it really engages the entire ICU team. It really helps the nurses know that there are other team members that are trying to do the same thing and improve patient care. It empowers nurses. We encourage nurses to speak in rounds and talk about these very important things. So it's a very special bundle. Bundles in the past, and there's still a lot of bundles, are really disease focused. And this one's more, I always say, more symptom focused. Yes. And those symptoms are so important. That's like the major change over this last decade. Symptoms matter. And who better than nurses to manage those symptoms?